Welcome to the Craniotomy podcast, where we peer into the minds of those in the front lines of neuromodulation and neuropsychiatry. I'm your host, Muhammad Nasser, with our psychiatrist, Dr. AlexanderHerman, and our neurosurgeon, Dr. DavidDarrow, who are the co-PIs of the Herman DarrowLab at the University of Minnesota. Thank you for joining us for another episode today. I'm actually really excited. We're hitting an amazing, impressive milestone of having an actual guest on the podcast. So I want to congratulate myself, the two of us, on this amazing achievement. Very happy to have Dr. Netoff, professor in the Department of Biomedical Engineering at the University of Minnesota. I know you've worked with Dr. Darrow for a good while, so we'll start with me just doing a quick introduction of myself, and then we'll have our guest do the same with our two doctors following up with their introduction. So again, my name is Muhammad Nasser. I actually work at the University of Arizona in Tucson as an equity and inclusion officer in the student affairs division at the university. So I do equity and inclusion work, looking into systems of marginalization, oppression, and on the other side of the spectrum, spaces for inclusion and equity for our staff. At the same time, I'm enrolled in the PhD program in higher education at the University of Arizona, which really is neatly connected to the work that I'm doing at the university.
Well, I'm Netoff, and I'm a professor at the University of Minnesota. I've been here about 14 years now, I guess my story is I started in psychology, and then I worked with Walter Freeman, who's sort of one of the grandfathers of computational neuroscience, and then decided I had to go more into neuroscience. Went to grad school at GW with Steve Schiff, who's a neurosurgeon, and then went to Boston University for my postdoc with Nancy Capel and John White, who are biomedical engineers, and then I've been at the U, and we'll talk about all of that and how that all ties in later. So.
Perfect.
Thanks. I'm so honored to be the first guest. I know this is only the second podcast, isn't it?
Mm-hmm. So, it is. So no pressure.
The second is a big milestone too, right? I mean, if you have two, you have a series. So This is great.
And whether we have another guest or not depends on how well you do today. So
true. Like if this all gets cut out, so that is just your introduction. And this, right? We'll see.
We'll see. Well, thank you for being here. So, Dr. Herman, you want to go next?
Sure, yeah. Tay, by the way, your feed is really crisp. I don't know what it is. You've got this, your face is really beautifully in focus and the backgrounds are slightly blurry.
Yeah. I've spent some time on my rig. So
you can tell. So I'm Alex Herman. I'm a psychiatrist at the U. I've been at the U for two and a half years, something like that. Yeah. 3.5 years now. My background is originally in physics as an undergrad, and I did my PhD in bioengineering as part of a joint MD PhD program, and then got into neuroscience, and then the work that I do with David that we talked about before. Yeah, I'll cut it short. I'll keep it there.
Great, David.
I'll cut it even shorter. Yeah, I'm DavidDarrow. I just joined the faculty at the university 5 months ago, but I've been here now for 7 years, and pretty much really before I even started my clinical program, I was already introduced to Tay and talking his ear off and bothering him. So it's been yeah. So I guess I've been working with Tay for half the time he's been at the U.
Half the time. That's what I was thinking. Yeah. That's pretty amazing.
Yes.
And we're just getting started.
What do you work on? What's the overlap between what you all do?
Yeah, so I think I originally I was introduced to Tay by actually Aviva Abosh on the day she left, pretty much, and since then we've been sort of tinkering around with looking at pretty complex data sets, and over time we've sort of developed a few clinical trials and approaches towards a problem that we talked about in those early days, which really comes down to the issue of, we've got all of these new devices that can really change the direction for certain patient populations, like epilepsy and Parkinson's and spinal cord injury that we've been working on. But a big question really remains, how do you configure these neuromodulation platforms specific to each patient in a way that is optimal? And we've been working on this problem for now 4 years, maybe 3 or 4 years, specifically with patient data. And we've learned a tremendous amount about how that sort of reflects mechanism, how much optimization you can do, and I think in a larger sense, the need for optimization for neuromodulation in general, something that it's been talked about a little bit, but I think it's now becoming more and more salient as more diseases have been shown to be affected positively by neuromodulation.
Mm-hmm. Tay, you wanna help us kind of delve deeper into how that connects?
I think one of the things and of course I thought about this before the podcast, is really what joins us is that I think we really all have a dynamical systems view of the brain, that we really think about the brain as producing really complex behaviors, but that there are really simple principles behind it. And when you put a few simple principles together, they can produce really complex behaviors. And I think that's what distinguishes us from a lot of others in how we look at it. And we're looking for these principles behind it. And once you understand those principles, then if you have an idea of what you want as sort of the normal or to restorative, then how do you push it to that spot, right? And that's where a lot of the controls theory and optimization comes from. And, as David mentioned, we have these tools that, they're stimulators, they're our little hammer, and now we're really figuring out how to use it, because for so long, we've just let these things just tap away at like one period frequency. And, we can get much richer dynamics out of it by really looking at the dynamics of the activity that we see and feeding back and very specifically tapping it when we think it needs to be tapped. And that's I think really what brings us together, because we all sort of have that same kind of view. And it's I come from a psychology background, and we all have a big interest in applying these kinds of tools to understanding how the brain functions, not just pathologically with epilepsy and Parkinson's, but how does it function cognitively, and what makes us human as a person, right? And so more than just the pathological activity.
How would you describe where we are today when it comes to neuromodulation, electrical stimulation at the individual patient level? Are clinicians involved in the customization of the stimulation to the point of actually reaching a point of improvement, or are we still not there when it comes to that level of customization? I'm wondering, at the individual patient level, where are we as far as these devices go?
Well, I think the therapies that have worked because, particularly like Parkinson's disease, where we give deep brain stimulation, and epilepsy, in certain locations, we can stimulate and we see a really good response. And I think we've been very lucky to find those quite robust therapies. But the dynamics of the systems are complex. So then once we found something, it's been really hard to figure out how to make it better, right? And we're finally just getting the tools that have the ability to deliver more complex waveforms, as well as to actually record from the brain while delivering stimulation, which is going to open up a whole new era of therapies. So we are, right at the place where we've got something to work, and they've been working rather robustly, and we've shown clinically that it works. But we have very barely scratched the surface of how to make that therapy better by tailoring it to a patient.
Alex, David, is that what you're seeing as well?
Yeah, I mean, would you say that they almost work despite the patient and despite the doctor in a way?
Well, I mean, I guess I would flip it around and say, they work because of just how tremendously good the body is at adapting to and making use of any minimal amount of therapy, right? Mm-hmm. And so it's like with the cochlear implant, right? And you just see that the brain can use any kind of information and adapt to it. And so if it's therapeutic in some way, the body can, the brain is quite magical at making use of it. So yes, despite the fact, but I think it's just the miracle that of how well the body and brain works to make use of whatever it can to heal.
So it sounds like to me, in a way, you're saying almost any perturbation to the system opens up an opportunity for it to settle in some less pathological state, or to take on less pathological dynamics, which it's kind of amazing if you think about it, right? Given that we don't really know, there really isn't any principled theory behind the stimulation that we're delivering. So why do you think it's the case that it works as opposed to making it worse? Is it kind of what you alluded to before, just that the body itself has a tremendous capacity to explore,
Well, we've thrown enough things at it, and I'm sure we've rejected a lot of therapies that didn't work, right? Yeah. So we're looking at the ones that provided something that does, but there's been a lot of trial and error.
Do you want to talk about how it works in the spinal cord case? Because I feel like that's pretty tangible, like how you do the optimization.
Yeah, that did you guys talk about the estand trial at all yet?
Not yet.
No?
No, we have not. No.
David, I'll let you introduce the estand, and then I'll talk about optimization. So.
Well, I think so. The estand trial was really, our effort to test the hypothesis that if we use sort of traditional spinal cord stimulation in patients with paraplegia, they have a thoracic spinal cord, so they can't move their legs, that we can. Others had shown in the past that, some of these patients, when you do some basic spinal cord stimulation, they regain some motor function. They were able to move their legs again. And there were small case studies that were reported, but it's exciting enough in spinal cord injury because there really are no therapies that we sort of took this on and started a trial, and we pretty much found the same thing. In most of the patients, we get a pretty robust response, and they gain some motor function, and it's really exciting. Not only that, but they gain autonomic function, they gain some blood pressure control, some bowel and bladder changes, some even sexual improvement. But from the beginning, and I can remember sitting in your office today talking to you about this issue, like, hey, I got funded to do this trial that we came up with, now we got to figure out how to actually do this. And you're like, wait a minute, what? What are we doing? And, in our situation, we wanted to design something that was real low cost. And we didn't want to have the patients there for, 20 days straight while we're testing out every setting and trying to figure out what works and what doesn't work. So the idea we came up with sort of, scalar, multi-scalar, where we said, okay, the first pass, we're just going to try to get a sense. And one thing that I notice about my patients is that they're very perceptive about changes in their body. And so the idea was to use them as sort of the neural network, so to speak, to tell us what's working well and what's not working well. Mm-hmm. And so we started off with this design where we essentially just asked them a series of questions at home that they can fill out in a survey, and all they do is they compare the setting that they're assigned to for that day with the setting that they're assigned to the day before, and every day we change the setting, and they do it in the specific sequence that we ask. And this is sort of the setup for how we did started with the optimization.
So you mentioned that the parameter space is 10,000 or not a million. How is what you're doing different than throwing a dart at the board and saying, is this better? another one, is this better? Another one, is this better? Because that seems like, how would you ever get to something that works? How is your approach different than that?
Right. So let me give my background or my version of this story, which is, so David came in one day and was like, there's this study that's been showing you could restore function by stimulating the spinal cord, and this is an easy surgery, and we should try it to see, because nobody's really replicated this. Do you think we should? And I was like, sure. and then about 6 months later, I get a video sent to me on my phone of this toe moving, with its, and what I knew was an accelerometer stuck to it, because David had helped make David make it in my lab the day before. And so I was like, is this what I think it is? And his response was, I'm turning on the second patient tomorrow, be down here at the hospital. So I came down, and we turned on this patient, and within 15 minutes, she was moving her legs. She'd been paralyzed for, I think, 6 years.
Wow.
And, it was amazing. Right. And, there were two things I really learned, coming out of that. One, that it seemed to work, right? And then secondly, when we walked out, well, are you kind of amazed that this worked? And she said, no, we kind of expected it to work. And we realized, first of all, you pretty much, as near as I've ever seen in my career to a miracle, you've just witnessed that, right? And I wish you were a little more enthusiastic about it, because this has been probably the most amazing day of my life, and you seem relatively blasé. And then David also turned to me and said, "Okay, you have to tune the stimulators, we had arranged this." And I was like, wait, what? When? Okay. And I said, well, I don't know anything about it. And he said, well, neither do I. And you can come up with something that's systematic and better than I would be doing if just randomly throwing darts at the board, right? And so the first question was, well, what do we measure? Because when you have an optimization problem, you've got to optimize something, right? And I was like, well, do we optimize the legs movement? Well, how are we going to measure that? And then immediately just kept getting into this quagmire of, I don't know exactly what we want out of this, because I don't really know what's going to work and what's going to get better. And and then you start thinking about, well, there's all the side effects, and how are we going to measure those? And it gets really messy really quick, right? And we had just read a paper about doing these pairwise comparisons, and one of the problems also is people are terrible at actually, giving a good quantitative number to, measure, how well are you moving your legs? Well, it's a 9. It's well, okay, and that what a 9 means for one person and 9 means for another person, could be very different, and even just, depending on their mood. And so, the pairwise comparison has the advantage of you're concretely asking 2 settings, and, they can think about what are all the benefits and pros and cons between those 2, but it's really hard to make a decision that's much more complicated than comparing those pairs. And so, that was sort of the first thought is we're going to only do pairwise comparisons, and the beauty of that is we can just ask them what they like. We don't have to really tell them, or we really have to make any particular metrics of what's good and what's bad. So I immediately loved that idea. I was like, we'll let the patient decide. And the more we thought about it, the more it became very patient-centric, right? Because the patient can decide what they like. They can think about, well, okay, yes, it has side effects, but those are tolerable, right? And also because it, is such an easy question once a day, we can let them go home and do it, right? So we could make a questionnaire, we could give them a schedule, right? And say, and the cool thing about this device is that you can program it with 15 settings, and then this patient can go switch between those settings. So out of those, 4 quadrillion settings, we can narrow it down to 15, right? And originally we just, threw darts at the board, right? And we gave them settings and a sequence to try, and then the next month they came back and we had all this data, right, where it was the patient said, well, I like this setting better than this setting, and this setting better than this setting, and I realized I don't have any way to analyze this, so I literally had to draw on the whiteboard what the settings were, and then arrows between all of the settings until I could sort of see which ones were pointing towards the better ones, so that we could identify what those better ones were, and then try to identify settings that were around that one and try those. For me, it's been a dream, right? Because that's the way you get to know it. Encourage me to come down and bring all my students to actually meet these patients, because it turns it from abstract data analysis to like, you really know these people and you really get to know their problems, and it also helps us really understand that we've been missing things. We've not been asking the right questions, or we've not been asking enough questions, so we can get in there and change things. And I know I kind of drive David crazy a little bit, because I didn't have a great plan on how to do this ahead of time, because I hadn't planned at all. And
we had a plan. It was like, we're going to do some gradient descent. And, right. That's what I wrote in the first grant. But, right. What we were doing the gradient descent on, I don't know. But.
We threw out gradient descent before we even started, right? So,
that's right.
We are going back to it. I'll talk to you about that. But we're going to finally come back to gradient design, but yeah, to have the flexibility to actually try things, it's been amazing. So, and now we have our 17th patient, right? And
yep.
I don't know how many settings we've gone through. It's probably at least 100, 150 settings per patient. Like most patients get set by a technician, and then they're never seen again. It's like, if it works, it works. And
so in the clinical setting, that's what Tay's talking about is, in the clinical setting, you get set by someone that, kind of knows reasonable settings. And then usually it's one or two settings, and you go home and you go on those settings. And if it works, it works. If it doesn't, they try to tweak it. But, there's no systematic approach towards the individual patient. What's cool about this approach that we like a lot, the pairwise comparisons theoretically give you the most discriminability, I guess. There's no better way to, get really good resolution on differences between settings. But what's really interesting is we personalize the models. So what Tay didn't get into is month by month, we accumulate more and more data for each patient. And we actually model that computationally, basically. And we try to build a model that's better and better every month. And every time they come back for another appointment, we pick settings typically that are in the area that we think are good compared to the last month. And so over time, their settings should get better and better and better. That's one of the reasons it's challenging to do this work, because it's hard to tell a difference over time if their settings are getting better. So it's hard for us to prove that the optimization is good. But it also allows us to, it's almost it's quantitatively guaranteed that no matter what, the patient always wins.
Mm-hmm.
We're always trying to give them better settings. They're never put really in a situation where they could get they get worse settings, because if the settings are worse, then they just go back to the settings that were better before.
Mm-hmm.
So it guarantees them a better outcome over time. So it kind of adapts to it could be adaptive to them technically. And so because we focus on each specific patient, though, then the problem is how do you then generalize this over all patients?
Mm-hmm.
It's sort of the opposite problem of science. Instead of trying to summarize everybody, we're diving into a very specific patient, making it better and better and better. And then we take a step back and we go, is this similar to all the other patients when we optimize them? And that's sort of how we do it, is we build an even bigger model that sort of looks at that. And thankfully, we've made some progress on that. So you can, from the ethical side, you can not only, focus on a very specific outcome for a very specific patient and guarantee them a good result or the best result that's possible by systematically exploring that space. But you could also then take a step back and say, how similar is this to all the other patients? And did we learn sort of the same thing over time that we learned from the other patients, and sort of make a comparison that way? And we can generalize from that. And that's where I think it's really interesting, because that tells us so much about, what to do in the future. And with the next patient that comes along, we take all that information into account. We don't just start over, we typically don't just start from scratch. We know kind of where everybody else has gone. And so we say, okay, well, we can avoid all the problems that, we got into with all these other patients when they explored in a statistical way. And we can start with an even better plan for the 10th patient, for the 16th patient. But you can imagine that if you did this on a clinical scale, 100,000th patient, you would really know the answer to this question.
Right. That's what I was going with, the individual patient level work versus how generalized this work is. And David,
Right.
you mentioned the ethical side of this work and making the case for how this is. Also, I think, Tia, you mentioned that this is patient-centric approach, with the patient having a level of agency over what's happening and what works for them. On the other end of the spectrum, are you wrestling with some other ethical issues that this work is kind of opening up, as far as some questions that you have? What is the issue on the other end of the ethics spectrum, if any?
It's mostly a question of the psychology of it. We actually think that there's benefit to just being patient-centric about the therapy. That's aside from the therapy itself. Now, I personally don't think that that's a problem. I think if patients feel like they're being heard because they're able to sort of participate in the process, that's nothing but good. Because no matter what, it sort of guarantees that the outcome is going to be consistent with more or less, the patient's wishes. Now, I think that's a fantastic, and I think that's a very sort of progressive view on, therapies going forward. Is it possible that, most patients are really, they want to advocate for themselves, and this gives them a space to do that. So I think if anything, it really opens up the avenue. It really makes you ask the question, like, why would you not do this? How could you justify not doing this kind of approach for neuromodulation in the future? In fact, can you even go to the FDA with a trial that does not include optimization? I think that's the ethical question that's really coming about for me, because if we know that there's variation in the efficacy of, a therapy for, say, Parkinson's, for example, and you say, okay, well, every patient we set to these settings because, and there's good reason for that. We've used these settings for a long time. We know that they work, whatever. But can you really say that they're the best settings for that specific patient? And what does it cost to do the optimization for a neuromodulation trial in the future? Does it cost anything? In our case, it really doesn't. It costs almost nothing per patient. And so how can you do a trial without optimization? Because then there may be a high risk that you do a whole study, no one's optimized, and you end up with a result that says this doesn't work, which is exactly what we saw with pain for DBS, pain treated by DBS, which was the original use of deep brain stimulation by Medtronic back in the 50s and 60s. So is it possible that we were missing something because it wasn't tuned to the patient specifically? That's the ethical side that's really opened up in my mind.
I want to throw a shout out to the patients. I mean, the patients have been alongside us in these experiments and have given us so much feedback, and it's tough on their side not to see how we're analyzing the data, right? They know they're blind, but I mean, they've been so willing and tolerating all the changes that we've made and adaptations, and it's just been fantastic to have them, and they've been really great throughout this whole study. So particularly, I mean, when we go to another study, we probably will have to be stricter, but the patients in this study were very, very helpful, and I love them all. And one of the things they always wanted was more, right? Can you give us more? Like, why only one setting a day, right? Why only stimulation setting? Why not do tons and tons of rehabilitation on top of it? I want more, right? And it's been tough because, we've seen other studies who have tried to do everything, right? And they've really gotten amazing results by pairing rehabilitation. But it also was a huge, huge investment, right? And to the point where it's just not scalable, right? Because it's like if it costs $800,000 a patient to give them the attention they need, then not many patients are going to get this therapy. So we have been strict in saying, look, we're providing electrical stimulation. We can't provide you anymore, right? But what we hope is that by moving you up into a new class, Asia class, where you actually can get movement, then we can enable you to go into rehabilitation and do all that rehabilitation afterwards. But for this study, we have to look at the effects of electrical stimulation alone. And I know the patients have been frustrated that because they've seen other studies where, they have taken patients and gotten amazing results out of them. But that's because, they've had tons and tons of money invested into each one of those. And these patients just would never get into those studies. And that's sad. And that's not what we want, right? We want to get them into the place where the rehabilitation can, infrastructure can go serve them. And it's felt like an ethical dilemma to me all along, but I think it's the right decision because in the end, it's what's our approach, I think, is what is scalable and what will, actually crack this problem open.
A lot of these therapies are moving more and more towards the psych realm, which we're excited about. For OCD, for example, or depression. And, I guess the question is, Alex, do you see that having this sort of feedback loop as part of the, neuromodulation algorithm? I mean, there's already TMS, there's already some therapies, VNS, that are being used. Can you imagine seeing that pairing neuromodulation therapy with optimization and the psychology of sort of participating in the patient-centeredness of it could provide, a substantial benefit to sort of the long-term effect on diseases in psychiatry?
Yeah, I mean, I would say that the fact that you've been so successful with a patient-driven approach gives me a lot of hope that this approach, the algorithmic optimization approach, will be successful in psychiatric disorders as well. Because I think most of maybe being a good psychiatrist is figuring out what really is going to make a difference to this particular person, because as psychiatric disorders are diagnosed by symptom criteria, right? So 5 of 9 symptoms of depression. What does that really mean? Why can't anyone just ask someone 9 questions and diagnose them with depression and treat them? Well, because it's about figuring out how that maps onto this individual person in their life, what's important to them. And so, of course, what we would really want is something where someone tells us, like, this is the thing that really matters to me, and this is what I want you to treat. And that might not be like, sleep disturbance or defined in a specific way according to some clinical instrument, or loss of pleasure on a scale of 1 to 4 or whatever it is, right? It might be something that is a narrative description of what they experience in life, or it might be something as simple as like, I felt like I was doing my job better today, or like my relationship with my wife has just been better on this stimulation setting, or and I think obviously that's a million times more complicated, but those are the kinds of things that really often matter to people. And so we definitely want to be moving to a place where we can tailor our treatments to things that matter to people, as opposed to these symptom criteria that honestly haven't done a very good job of helping us design new treatments, right? And so I definitely think that that is extremely hopeful. I think all of the kinds of issues that are coming up with this are going to be amplified in psychiatry. One of the things I was wondering is, like, if you've had an experience, not just where someone tells you that the settings feel different even though they're the same, because maybe that's a situation where something's actually changed. I don't know. There's been some plasticity.
Hysteresis or
Exactly. Yeah.
Oh, we've had patients tell us, like, the same setting that, like, a couple days later felt completely different to them, and they knew it was the same setting. So they
Have you had the situation where the person reports a setting is better, even though some objective measure like limb acceleration is worse? And what do you do in that kind of situation where there's a dissociation between the patient's goal or the patient's report of their progress and these objective measures? How do you approach that?
Well, the only objective measures we really have are of leg movement. And so then, we sort of assume, well, it's spasticity or pain or comfort or something else. But we don't have good metrics of those to really identify that they do or don't correlate with it.
So the general way is, we often, so for example, in a given month, for one specific type of setting, we have usually 8. So we have 8 settings that we test. And we actually do the pairwise combinations between all combinations of those 8 settings. So we actually have multiple, repeated tests for an individual setting and we compare sort of the transition states to other settings. So in truth, we actually have a lot of repeatability. And in some cases, like, for example, during COVID, when patients couldn't get back to get, reprogrammed,
right,
we had some patients that had the same settings for 3 or 4 months in a row.
Longer, yeah.
And so the nice thing about that is we get like really good repeatability and the model actually converges better. And we found that in
we still
those
have 2 patients that we haven't reprogrammed since February. So they're
right,
still going.
They're still going. So what we learn is, if we're given hundreds of comparisons, our model, predictability, it starts, going above 90%, 95%. We get really good predictions for these patients. And it's because, there's always going to be some fluctuation, whatever, one way or the other, with some state dependency based on the day. But if we're able to, build in the math, how much to repeat and whether or not there needs to be repetition, like that can be done in an algorithmic way from sort of a Bayesian sense. Is setting 2 always flip-flopping, good or bad? Like, is that a setting that we should really focus on again to figure out, these are the kind of things that we can easily build into the algorithm to pick, like, hey, we're going to change your sequence, this second month, we're going to actually do, setting 2 a few more times. These are things that could be done in a very algorithmic way to help with that if that's an issue. We sort of early on, there's a lot of, flexibility here where you could say, we're really concerned about, for example, depression, and we want to make sure that when we change the setting, we're not increasing anxiety. You could say something like that. You can actually build into the cost function. We're going to actually look at, depression and anxiety, and then we're going to do the, selection based on that. It doesn't have to just be on one outcome. Or you can say, I want to just look at the, model that we built on the patient, but I also want to integrate in my clinical score that I use, whatever, my PHQ-9 this month or this day, and I'm going to use that as a quantitative outcome as well. And you can actually just combine these, in a way, and use that as your optimization goal. So there's so much flexibility in terms of how we do this. I think the nice thing is that for things that we just don't really understand how to characterize very well, the patient-centric approach where we're using the binary comparison is really amazing, because it will tell you at least, is there any signal here?
Right.
And that's kind of how we approached it from the beginning. Like, is there anything here that we need to be knowledgeable about? And the answer was definitely yes. And so once you take it from that, then you can say, okay, well, we got you close. how do we get you even better? And that may require something closed loop, something quantitative, something electrophysiology. It might require something that's on a time scale that's different than the way that we've done this study, but at least it gets you in the neighborhood,
Also, when we started this, we could have asked them a list of questions and to rank them how important all these different aspects are to them and which one we're going to shoot for, right? And often, they really don't know what's important to them until they've actually seen the effect. And they're like, I didn't realize this could happen. And now I realize that I didn't, that's more important to me than I realized, right? And it suddenly changes. And it can see, definitely when we go into this, the psychiatric space, it's going to be much more like that, right? Because people's expectations and then not realizing, what they can have and how important that is to them, it'll be a path of discovery, right?
As a complete outsider, I can just see the amazing potential of the patient-centric approach evolving into the holistic approach that would include the support system, that would include the family. Yeah. How do you prepare family members and support systems to engage the patient in that treatment? So amazing to hear you talk about it. I don't know if there are any last thoughts or questions that any of you have. Any questions about higher education and inclusion? No?
I was just caught off guard with that question. So
that's what I do best, I think. Well, I think with this, we're coming to the conclusion of our second episode. Again,
thank you guys for having me.
Amazing.
Yeah, thank you for coming.
Having a guest, Dr. Tay. Thank you so much for being with us, and we look forward to continuing the conversation next time.
Okay.
Thank you very much. Thank you, Tay. Thank you, Mohammed.
Certainly, my pleasure.